Hey everybody, welcome back to part 2 of total shoulder arthroplasty or total shoulder replacement. Just to do a little bit of a review from our last presentation. So the first half, we discussed a little bit related to anatomy. And remember, it's really important that you understand anatomy of the glenohumeral joint as well as how it articulates to the scapula, the acromioclavicular joint, the scapulothoracic joint. And it's really important to understand that there is this sort of 2-to-1 ratio of the scapula to glenohumeral movement for overhead reach. And that's going to change a lot, as you will see today, when patients have had, especially a reverse total shoulder replacement. So we have to keep that in mind as we're performing our rehab. We also talked about scapular movement and how important it is for the upper trapezius to work with the serratus anterior and the lower trapezius, as well as somewhat with the deltoid coming from the humerus and the other muscles attaching to the scapula to allow for scapular upward rotation. So those are our main muscles that we're definitely going to want to think about as we're performing rehab with these patients. So we talked about the patients that tend to have this surgery, and they tend to be patients who have significant osteoarthritis, but also things like rheumatoid arthritis, significant rotator cuff tears, avascular necrosis, and then in certain cases, a really bad fracture might also lead to a shoulder replacement. So they perform either a total shoulder arthroplasty, a reverse total shoulder arthroplasty, or possibly just a humeral head replacement. So that humeral head replacement is just that. It just replaces the humeral head without changing anything on the scapula. And this one is done if there's just some inflammation of OA that's significant and only to the humeral head. Whereas things like avascular necrosis, significant rheumatoid arthritis, those things will lead to a total shoulder. And if that total shoulder didn't work, they may choose to do a reverse total shoulder. They also do reverse total shoulders when there's significant rotator cuff deficiency. So the rotator cuff tears are very bad, or there just is not very much rotator cuff tissue that's viable enough to be able to perform a normal rotator cuff repair. So we talked about the total shoulder technique. I think the thing you want to be most aware of with the total shoulder is that they're coming anteriorly through the deltoid and pectoral muscles. They also usually have to take away the subscapularis, at least partially cut through that tendon to perform the surgery. And so you may be missing all or most of the subscapularis muscle to perform internal rotation, as well as just stability. So you just want to keep that in mind. We won't go through the surgery itself. The reverse total shoulder is what I consider one of the most interesting surgeries. Remember, basically the head of the humerus is being transferred to the acromion, so to the scapula. And on the humerus, we actually have the socket portion. And so they just literally flip it. And when they do that, they really don't try to spare the rotator cuff a lot. So you really don't have a lot of rotator cuff, usually rotator cuff tendon usage after this reverse total shoulder. So we're not expecting a lot of rotation to be able to be performed since we don't have those rotator cuff muscles. We should have some of the other muscles that also help with rotation that you might be able to use for that. The deltoid turns into the primary muscle for overhead movement, and it allows for compression of the basically the humeral head component into the acromion on the humerus. Again, very interesting surgery, and we'll talk about some specifics related to the rehab here in just a second. Again, won't go through the surgery itself. Complications, we talked about these a little bit. I think these are important to keep in mind. The outcomes for these surgeries is not necessarily these patients getting back to 100%. And most patients aren't expecting to get back to 100%. So you want to provide lots of patient education throughout your rehab, and especially at the beginning, helping them recognize that for a lot of this surgery, they're not going to be getting full range of motion and they're not going to have full strength on that side. So the biggest complications that we see, like we said, subscapularis oftentimes doesn't really work because they have to cut through it with the total shoulder. There also might be some malalignment issues. For the reverse total shoulder, we have that scapular notching, which is very common. About 2/3 of the patients get this notching, and basically what it means is the prosthetic hits up against the scapula during adduction. So it can be painful when you're trying to bring the arm across the body because of the alignment of the prosthetic. So we want to start with patient education, as I said earlier. And patient education is really, really important. If you can see these patients preoperatively to provide this education, then it's very, very helpful because there's a lot of things they need to know and understand. One thing is that a sling is going to be worn for at least 3 weeks. And we're not going to talk about a lot of other shoulder surgeries in this class. We only have a couple of shoulder surgeries that orthopedics really do. But recognize that this surgery and rotator cuff repair, having a sling and understanding how to put on a sling and take off a sling is really, really, really important for this patient population. Certain patients who do not have a rotator cuff or just have very poor bone quality, so patients maybe with rheumatoid arthritis, they are usually put in what's called a limited goals category, meaning that we're not expecting them, again, to make huge, huge, huge gains in range of motion and strength. And so these types of patients should be wearing sling all the time to basically allow for as much tissue repair as possible during those first 3 weeks. Everybody else, usually they'll say that you should be wearing it to help make you comfortable. And so you definitely want to be wearing it at night and in crowds. And you guys, if you've seen lots of patients with who've had any type of shoulder surgery, the patients will complain about nighttime being very, very uncomfortable. Most of them have to sleep in a chair for the first couple of weeks after surgery. So that's common. So don't let them get discouraged by that. They just need to be able to find comfortable positions. And wearing the sling is actually a lot more comfortable for most of your patients. It says supine lying only for sleep for 3 to 4 weeks, meaning you're not lying on your side. Again, a lot of people do sit. They sit in a chair or kind of propped up on a couch, and that's kind of common. So again, they should not be laying on their side at all. And we're avoiding active range of motion for the first 4 weeks. They should not be using that arm, basically, at all for the first 4 weeks. Also, no driving. So obviously you can drive with one arm, but the idea is that if there was to be something you had to do quickly, you might automatically start using your involved side. So they basically say no driving for 4 weeks. If you can get them preoperatively, that's great. So you want to try to keep as much shoulder mobility as possible if you're working with them. And again, even preoperatively, don't lie on that shoulder because it can be really uncomfortable. And then you're also just going to educate them on what's going to happen after the surgery. I was pretty excited last year in May. The Journal of Orthopedic and Sports Physical Therapy did a systematic review of total shoulders and reverse total shoulders. And so I was able to kind of use that information to supplement our presentation here. So I just want to make you aware that there is a guideline through Journal of Orthopedic and Sports Physical Therapy. If you do want to pull that up and use that as a reference and read more, that's a good resource, I think, to have available. Okay, so the first phase, and if there's anything that's going to be different between the total shoulder and reverse total shoulder, I'll be sure to let you know. Most of the time, the rehab is very, very similar with those two different surgeries, and even with the humeral head replacement. So the first 4 weeks is our first phase, and you can see we talked about all of the things that they shouldn't be doing during the first 4 weeks. But our goals is that we really want to allow the soft tissue to heal. We also want to gradually increase passive range of motion of the shoulder. So our focus through this time period is passive range of motion. But we also need to make sure that the patient has full range of motion at the elbow, wrist, and hand. And so if they're in a sling all the time, you can see how the elbow extension might start to get limited, as well as any wrist and hand movement. So we need to be aware of that and make sure that we're also assessing and possibly treating elbow, wrist, and hand. Also want to try to decrease muscular inhibition. This goal has to be the hardest thing that we have to work on as therapists for any patient with shoulder pain. Again, any of you who have worked with shoulders for a long time, what makes it so difficult most of the time is that you cannot improve range of motion because of muscle inhibition. So the brain is basically telling the muscles to all tighten up and not release because basically the body wants to protect the shoulder. And this can be a big problem. And in lab, if we do have lab and we talk about shoulder, I'll make sure we spend a lot of time kind of learning how to feel the shoulder and understand when muscles are inhibiting movement versus when muscles are tight versus when joint is being inhibited and causing inhibition to the movement. So really during this period, you want to be very gentle with your passive range of motion so that you don't end up getting muscles guarding and muscles tightening up around the shoulder, which is very hard to do. I'm not going to lie. It's a hard thing as a therapist for you to get past. And trust me, the patient's in a lot of pain when you're trying to do your range of motion. You guys have seen it. It's not fun. It's not fun for anybody. So during this first phase, we also would like for them to be able to do most of their ADLs, but we're going to have to modify them. So you have to have a conversation with your patient about that. So for patient education, there's lots of it, like I said, and especially in this first phase. The patient needs to recognize that they're going to have swelling and discoloration even on the chest, and that's going to occur over 4 to 8 weeks. I don't think people expect their chest and their back to get so irritable, but it definitely happens. We already talked about the sling, using it when they need to, and no driving. And then we just really want to make sure we're avoiding any sudden movements, including some like little bit of weight bearing or anything like that on the involved side. So another big piece of education, avoiding active range of motion. That's why the sling is helpful, because the sling doesn't really allow them to do active range of motion. So if you're worried that the patient is moving it too much, you can basically tell them to wear the sling all the time because they really need to allow that soft tissue to heal. It's just like with a rotator cuff repair. It's really important that they have this time to heal. And there are very few surgeries where we're really sticklers about making sure that they're not using active range of motion, but this is definitely one of the important ones. For a reverse total shoulder, they should not basically be combining the movements of shoulder extension, adduction, and internal rotation, which is putting your hand behind your back. They should not be performing that for at least 6 weeks. Okay, so that movement is completely taboo for 6 weeks. Also, you want to educate your patient on what's happened to the mechanics of their shoulder following a reverse total shoulder. So we talked about how that scapulohumeral rhythm is 2 to 1. So if you think of the shoulder as having 180 degrees of overhead movement, 120 degrees should be coming from the glenohumeral joint, and 60 degrees should be coming from the scapula. However, after a reverse total shoulder, that ratio changes from 2 to 1 to 1.3 to 1, meaning that it's almost a 1-to-1 ratio between the glenohumeral joint and the scapula for overhead motion. So it's really important that we're strengthening and thinking about those parascapular muscles, because we have to get as much mobility from the parascapular muscles and the scapula as we possibly can, because that's what's going to help with trying to get as much overhead movement as we can. So we just want to educate the patient on what that's going to look like. Again, we're still in the passive range of motion phase, so we're not doing active range of motion overhead yet. But as you start to perform the rehab, you want the patient to understand what to expect from their shoulder now. So specifically for treatment, I have here treatment day 1, but there's a lot of experts that would say you don't even do anything until 4 weeks after surgery. So you don't even start this stuff until they are allowed to start doing a little more active range of motion and get out of the sling. So you may be getting that from your doctors. I'm guessing that's pretty common in China, honestly, to make that recommendation. But if you do get them right after surgery, you can start doing passive range of motion. Passive range of motion, internal rotation only to the chest, and external rotation must be in the scapular plane to 30 degrees. So very relatively small range. I think 30 degrees is, we've talked about, if you've been in any of my classes, is a pretty functional range of external rotation. And then you also want to be doing a lot of movement at the elbow, wrist, and hand. It's the day after surgery, so we're hoping they have some good pain medication that they're using, and we can use modalities and ice to help decrease the pain and swelling. After the first day, we're going to start doing more scapular exercises, so scapular isometrics, and then we're going to also just start continuing with passive range of motion. We also can start doing very small contractions of the deltoid muscle. So deltoid, submax, pain-free isometrics. And then if they can achieve greater than 90 degrees of passive flexion and abduction, we can start doing active assistive range of motion with a pulley within that first 2 weeks. So again, it's only if they can get over 90 degrees of passive overhead movement, okay? Otherwise, no pulleys. Also, as we go past the 10-day mark, we can start doing more isometric type things. We also can start increasing active assistive range of motion. Usually, I'm not going to progress those things until about after the first month. So again, this is saying that the patient has been instructed to perform rehab right away, but most of the time you're not going to get these people till after 4 weeks, and so you can progress just like this timeline and you should be fine. You also want to start strengthening the wrist, elbow, and hand. And so to progress, we actually have some pretty good range of motion parameters for you at this point. They should be able to tolerate passive range of motion exercises by the end of this phase. And passive range of motion being you the therapist, doing the motion, and them not having huge amounts of muscle guarding. We also would like their flexion abduction to be about 90 degrees. So basically scaption or overhead movements to be at least 90 degrees. External rotation in the scapular plane to 30 degrees, and internal rotation in the scapular plane to 60 degrees. You also want to make sure that whatever muscles they do have intact, they always are going to have the deltoid, they might have some rotator cuff muscles, and they will definitely have the scapular muscles. Those should all be turning on correctly with isometric contraction. So those are important milestones to consider before you move on to phase 2. So again, you'll notice passive range of motion. So while we did talk about possibly starting some active assistive range of motion, unless they're more like 6 or 7 weeks after surgery, I would continue with just passive range of motion during the first phase. The second phase goes until 8 weeks, so about 2 months. And at this time, we're going to start doing more active range of motion. So this is where that goes. Passive range of motion will continue, but we're trying to get more assistance from the patient. So active assistive range of motion, and then active range of motion is very appropriate. We want to continue with modalities and ways to control pain because they will have pain. I'm sorry to say, this is a painful surgery. Reestablish dynamic shoulder stability. So what that means is we want to get those stability muscles. If it's just the deltoid, it's just the deltoid. If there's rotator cuff still intact, it's the rotator cuff. And we want those to work so that when they try to raise their arm in active range of motion, they have stability through the glenohumeral joint. So you really are making sure that they have all those muscles turning on through that active range of motion. Scapular muscles as well. So we want to make sure we get serratus anterior, lower trapezius, and upper trapezius all working with that overhead motion. If they're the limited goals group, so remember that's the group where we're going a little bit slower. We're not expecting them to get full range of motion at the end of all of this. They were the ones who probably had really bad rotator cuff issues, really bad bone health issues. So for them, we're really focused on pain control and then trying to figure out ways that they can perform ADLs using that arm as much as possible. Patient education. We should get them out of the sling at this point. So they're using it possibly only for sleeping if they need to. Again, it does help with pain control with sleeping. And I always feel like sleeping is a really, really important goal for your patients. And so if you can find ways to help them sleep better, and that includes the sling, that's totally fine. Other patient education, they shouldn't be lifting anything heavier than a coffee cup. Okay, so I don't know how many kilos that is, maybe 1 or 2. It should be very light, very, very light. That would be a really big coffee cup with a lot of coffee. So probably less than that. They should not be supporting their weight on their hands, so no weight bearing on their hands, no weight bearing through the shoulder. Again, no sudden movements. They need to be going slow. And then just the reminder about the reverse total shoulder and that scapular rhythm and how it changes so that reverse total shoulder patients can understand the importance of all that scapular exercise that you're giving them. At this point, we can start doing horizontal adduction. So if you remember, with the way that the shoulder is replaced, we have to be a little bit careful with things like adduction initially. It's kind of like with the hip. We're worried that that could dislocate. So we can start doing those things now in the second phase and then really focus on range of motion, active range of motion in all other planes, especially in the scapular plane. Continue to progress strengthening of the scapula and make sure the wrist, hand, and elbow are okay. And then we can start more in kind of progressing isometrics of the rotator cuff. So to move out of phase 2, they should be able to tolerate active range of motion, passive range of motion without any muscle guarding. They should have at least 145 degrees of passive range of motion into flexion and 120 into abduction. And again, as I said, or kind of alluded to earlier at least, a lot of these patients aren't going to get more than that. So if you don't get all of that by the end of phase 2, you could keep trying to work on it. But I try to just tell my patients, let's figure out how we can do functional things with what you have. And that doesn't mean I won't continue to work on passive range of motion, but I want them to be able to use their active range of motion as best they can. And so other passive range of motion measurements, external rotation to 50 degrees, internal to 60, and then shoulder overhead active range of motion to 100 degrees. And that's the much harder one, I think, to get because, again, we don't have as much strength as we did before. So phase 3 is going to be up to 3 months. And so we really kind of end there at 3 months. But like I said, some of your patients might go slower. So don't be surprised if you have an older person who's got other issues medically. They may be going slower than this time frame. But it's during this time that we want to stretch. We want to make sure that the soft tissue is lengthened enough to allow for full passive range of motion for this patient. But also we're spending a lot of time on strengthening and power and endurance so that they can go back to doing their ADL. So the idea is we want them during this phase, which is only less than 3 months after surgery, to be using that involved side for their ADLs, for their cooking, for those kinds of things. And we want them to be able to control that scapular movement with the glenohumeral movement. But at the same time, we're educating them not to lift more than 5 pounds, which means really less than 3 kilos. So we're sticking with, again, more endurance and light strengthening at this point. They shouldn't be doing any sudden lifting. They can do some lifting, again, up to 5 pounds or 3 kilos, but they shouldn't be doing any sudden movements. So at this point, We really are, again, focused on active range of motion overhead, as well as internal and external rotation. We're gonna continue to advance passive range of motion. And at week 8 to week 10 is when you can start with the reverse total shoulder group, start working on the motion behind the back. So you're waiting at least 2 months after surgery before you're having them do movement behind the back, okay? And again, like I said earlier, you don't want to do more than 5 pounds, but you can elevate 1 to 3 pounds. And I would keep that below 90 degrees of flexion or 90 degrees of scaption. The second half of phase 3, you're going to add more resistance. So you're going to start using things like TheraBand, and you're going to really start doing strengthening of external rotation and internal rotation. So we really weren't doing that before. We were just doing range of motion, and now we're going to start doing more strengthening for external and internal rotation. So our last part of phase 3, we really would like for them to be able to do active range of motion in all planes, and then you'll see active range of motion measurements now are here. With elevation, you want at 120 for active range of motion. So we went from passive at the end of phase 2 to active range of motion at phase 3. And again, because of their strength issues, you're less likely to be able to get to these goals quickly. So just keep that in mind. Phase 4, we are kind of changing this. If you remember, we've done return to sport as phase 4, but with this patient population, they tend to need a little bit more rehab just for ADLs. And so we kind of go until 6 months for more advanced strengthening because they need it. So these patients you might be seeing for up to 6 months, and hopefully China will allow for you to be able to do that because it's going to be helpful for these guys. So our goals are full pain-free range of motion and just increases in strength. We also can progress to closed chain activities at this point. So these we can do these for the month 4, 5, and 6. And it's going to be important that we, again, start progressing strengthening. So we want to explain that we want to avoid activities that stress the anterior capsule. So basically that's going to be like throwing motions, anything with external rotation and abduction, kind of above 80 degrees of abduction. So kind of like this picture here of this discus thrower. Those kinds of motions are definitely going to put the anterior capsule on more stress, and they're more likely to dislocate. So we want to avoid those motions at this point, but we're going to continue strengthening exercises. So that's what you see here. We're going to do more weight bearing, things like quadruped. We're going to start doing plyometric and sport-specific activities if they want to go back to sport. And we're going to progress their home exercise program. So they're really hopefully doing home exercise at this point. And then the last phase, phase 5, is return to sport. So that's, again, that's after about 6 months. They can start playing with return to sport at month 3 to 6, but we really don't want them doing full participation in sport until about 7 or 8 months. And what you have to recognize is that about a third or more have restrictions. And it's important that you, again, we're educating our patients that they're still going to have restrictions. They're still going to have strength as well as mobility restrictions. That's pretty common. But they should be able to return to kind of basic sporting activities like cycling, golf, swimming, skiing, tennis. They even say football, which I think is a little bit crazy. But it is being recommended that they can do those kinds of things. But they really should be avoiding more high-impact, kind of arm-focused stuff. So I guess when they say football, they mean soccer, and that's probably just fine because there isn't a lot you're doing with your arms. But things like martial arts, rowing, rock climbing, those things are probably off limits for this patient population. So again, we have a very important role, I think, in rehabbing these patients, but don't get discouraged if you're not seeing huge changes and huge gains with these patients from the beginning or throughout your rehab, because oftentimes there's a lot going on with these guys. So you can be a very helpful person to be involved in their rehab, and so hopefully you'll find it rewarding, especially if you kind of understand what to expect from them, and they understand that as well.